go!
This guy, I learned about this guy a few years ago. He came onto the podcast. And then after the podcast, I read his book, Lies My Doctor Told Me. And it's one of my favorite books because he's a doctor, right? And I was like, wait, what is this guy talking about? Met him a couple of times at a couple of different low-carb meetups and whatever you call them, clinics, what have you. He's a great guy to have around, and you guys will love the next 50 minutes with Dr. Ken Berry. Doc, take it away.
All right. Thank you very much. Hello, ladies and gentlemen. I'm going to try to share a PowerPoint with you if I can figure this out. Application window. Might take me just a second here. There we go. All right. Can you guys see that?
Not yet. You need to hit the computer icon there, click on the application, and then click go.
Share. Got it. Okay.
There we go.
Beautiful. Okay. So that looks good?
Yep.
Okay, beautiful. Okay, so what I'm going to be helping you understand today is how to predict type 2 diabetes years before it happens, up to 10 to 15 years before someone's ever diagnosed with it. You can actually prevent it. And as a common sense person, you understand that anything you can predict, you can also take steps to prevent. And that's what I'm all about, is let's just prevent this from ever happening. So up to 10 years before it starts, absolutely doable. You can do it. And also I want you to teach your doctor how to do it. Not only so your doctor or healthcare provider can do it for you, but also so they can do it for all their other hundreds of patients. That's the power of what we're doing in this movement, is we're teaching patients so they can teach their doctor, so their doctor can then help hundreds more people. So my goals are to make you smarter than your doctor, but also in the process to help make your doctor smarter as well, so they can help their other patients. I want to make you completely immune to type 2 diabetes, and I want you to be able to know how to cure type 2 diabetes in either yourself, your friends, your loved ones. That smart ass guy you don't like, you can just let him keep it. You don't have to help him, but everybody else that you care about, you can use this information to diagnose type 2 diabetes years before it starts, and then tell them exactly what to do based on all the information you've gleaned in this NSNG Summit to prevent them from ever becoming type 2 diabetic and suffering all of the egregious complications. Some quick bullet point facts. 240 billion in the US is what type 2 diabetes costs a year. 29 million people have type 2 right now. And every single one of those, if they're properly diagnosed, can reverse that type 2. So we could literally wipe out the entire type 2 diabetes epidemic with this information if enough of us share this information. And then some smart people in a think tank predicted by the year 2050, a third of adults would have type 2 diabetes in the United States. Now, the current paradigm makes it very difficult to predict type 2 diabetes because it doesn't give you any useful information. When you ask your doctor, hey, what caused my type 2 diabetes? They say things like, well, it's genetics. We don't know what percentage that causes. It's lifestyle. You're lazy. You probably just lay around too much. And then maybe it's diet some. We don't know. Probably if you're, drinking Coca-Cola and eating honey buns all day, that might contribute, but we really don't know. So I looked up on the Centers for Disease Control. They're supposed to be pretty smart people who are supposed to understand these things. This is a cut and paste direct quote from their website. And this is under what causes type 2 diabetes. This is their verbiage. Insulin is a hormone made by your pancreas that acts like a key to let blood sugar into the cells in your body for use as energy. That's true. If you have type 2 diabetes, cells don't respond normally to insulin. And that's also true. This is called insulin resistance. Your pancreas makes more insulin to try to get cells to respond. That's true. Eventually, your pancreas can't keep up and your blood sugar rises, setting the stage for prediabetes and type 2 diabetes. Okay, all that's essentially true. But remember, I looked under what causes type 2 diabetes. Read that paragraph. Do you see is there a cause mentioned? Is there a cause even hinted at? No, there's no cause. Under their headline, what causes type 2 diabetes, they don't tell you the cause. And it's because we're currently operating under this ignorant paradigm that gives you no predictive power and gives you no real causative power as to what the heck's going on. So I propose a new paradigm for type 2 diabetes. We know exactly what causes it. Maybe it's 1% genetic, maybe 1% lifestyle. It's 98 or 99% your diet. What you eat, what you don't eat, what you're eating that you should not be eating. That's what causes type 2 diabetes 100% of the time. So type 2 diabetes actually is a carbohydrate overdose, chronic carbohydrate toxicity, carbohydrate poisoning, if you will. If you start thinking about type 2 diabetes with that paradigm, then all of a sudden you have the power to say what's causing it. You also have the power to say what you can do, what you can change to prevent it. So here's the current definition of type 2 diabetes. If you don't have type 1 diabetes and you have a fasting plasma glucose of over 126, your doctor can use that number to diagnose you as a type 2. If you have a 2-hour glucose tolerance test over 200, that's diagnostic. If you have a random blood sugar above 200 at any time of the day, automatically you're a type 2 diabetic. No ifs, ands, or buts. Or if you have a hemoglobin A1C greater than 6.4, then that last one is the one most doctors are going to use to diagnose you with type 2 diabetes. Pre-diabetes, and this is very important. Pre-diabetes is a fasting plasma glucose of 100 to 125. A 2-hour GGT of 140 to 199, or an A1C of 5.7 to 6.4. So type 2 diabetes is a spectrum. It's not like a light switch. You either got it or you don't. It's either yes or no. That's completely the wrong way to think of it, even though many doctors think about it exactly that way. This is a spectrum. You start developing early stages of hyperinsulinemia, of insulin resistance, of prediabetes years before you're formally diagnosed as a type 2 diabetic. And at any point on the spectrum, if your doctor knew which labs to check, they could catch it early and say, whoa, you're moving towards type 2 diabetes. What can we do to prevent you from ever becoming a type 2 diabetic? And so since many doctors don't do these things, that's why I wanted to educate you today so you can start doing it for yourself, your friends, and family, and also help your doctor understand. So if type 2 diabetes is carbohydrate toxicity, now that we know that's what causes it, now we can say, well, how do we predict it? And therefore, how can we prevent it? And also, how can we reverse it? Because if you go by the paradigm that's listed on the Centers for Disease Control website, you can't do any of these things, okay? Let me tell you a quick story about my neighbor's dog, because a lot of people get hung up about, did you reverse your type 2 diabetes? Did you cure it? Did you put it in remission? So my neighbor has this dog that barks all the damn time. And my other neighbor, who has to sleep during the day, got tired of it. So he started putting a little mercury in the dog's food bowl every day. The dog started getting sick. His hair started falling out. He didn't bark anymore, which was good for all the neighbors. But eventually my neighbor busted my other neighbor poisoning his dog and had him arrested. So obviously he was in jail. He couldn't poison the dog anymore. So immediately the dog started to get better. He started, his coat, his hair, everything started to get better. His energy came back. He started barking again, unfortunately. But so how would you describe what happened to my neighbor's dog? And so he was being poisoned with mercury. That's what was wrong with him. But now that my neighbor's in jail and is not poisoning the dog anymore, would you say that dog's mercury poison is in remission? Is that how you would describe that? Or would you say that it's improved? Or would you say that the dog has been cured of mercury poisoning? And so now that we have this new paradigm of type 2 diabetes, I think it's quite obvious. If you stop poisoning the dog and the dog gets better, you've cured the dog. You haven't put the dog's mercury poisoning in remission. Now, let's talk about some physical signs of type 2 diabetes that can literally come decades before you're actually a type 2 diabetic. So as soon as your insulin starts to go up and you develop hyperinsulinemia, as soon as you start developing insulin resistance, you can start having these physical signs. And you can see these across the room on a friend or a loved one and say, hey, you've got acanthosis nigricans. This is absolutely caused by hyperinsulinemia. It's one of the earliest physical signs that you can look at somebody and say, hey, you either have type 2 diabetes or you have prediabetes, you're moving towards type 2. Another, skin tags. So many people think that skin tags are 100% genetic, including doctors. Nothing could be further from the truth. You do develop a 1 or 2% propensity to develop skin tags from your genetics. There's no doubt about that. But 99% of the cause of skin tags is hyperinsulinemia, prediabetes, insulin resistance. And so I can look at this person from across the room and know that they're metabolically unhealthy. They either have type 2 or they're moving on the spectrum towards developing it. Another one is central adiposity. And this picture is a little over the top. Very commonly, people can be very slender and have just a tiny belly pooch that just is cute almost. That is a huge indicator of hyperinsulinemia, fatty liver, metabolic syndrome, insulin resistance right there. And so if in another otherwise skinny individual who looks very healthy, if they have a little belly pooch, they have hyperinsulinemia, they're moving on the spectrum towards type 2 diabetes. If you have any of these things, then you have metabolic syndrome, hyperinsulinemia, and you're moving towards type 2 diabetes, even if you don't have it yet. Hypertension, gestational diabetes, fatty liver, PCOS. If you have a very low HDL for no apparent reason, it's hyperinsulinemia. If you have high triglycerides for no apparent reason, it's hyperinsulinemia. And keep in mind now, we know what caused the hyperinsulinemia. This is not like, oh, I don't know, I guess you inherited it. You're eating too many damn carbohydrates. That's why you have high triglycerides. Sleep apnea, and so as all human beings get older, they become more insulin resistant and they tend to have hyperinsulinemia easier. And so if you're over 45, you're at a little bit increased risk. And it's not because of your chronological age, it's because you have a higher propensity to develop insulin resistance and hyperinsulinemia. Any mental health diagnosis puts you at increased risk of type 2 diabetes, including dementia. So all of these things are under the umbrella of metabolic syndrome, which I predict over the next few years will start to be called what it actually is, which is hyperinsulinemia. Now, let's talk about some black and white evidence, things that you can actually go to your doctor and say, hey, order these tests for me. There are 2 tests I particularly love because they're quick, they're easy, they're relatively inexpensive, and you can check them any time of day. You don't have to be fasting to have either one of these checked. So, if a doctor has a very busy medical practice, they can't have every patient come in at 8 a.m. for fasting blood work. It would just jam up the system. These 2 tests can be checked any time of day, and they're going to give you very good information. And I'm going to talk to you about these tests. I want you to write these down because these are important. You don't have to fast. They're not perfect. No test is perfect, right? But they're very, very reliable and they give good information. So the hemoglobin A1C is when sugar binds to hemoglobin and glycates it, right? That's glycated hemoglobin. Now, what a lot of people don't know, many doctors don't know this, you may have to teach your doctor, is that yes, glucose glycates. There's no doubt about that. But actually, fructose and galactose, so that's the fruit sugar and the milk sugar, they actually glycate your hemoglobin and all the other cells in your body faster and easier than glucose. So drinking that big glass of skim milk or that big glass of fruit juice, that's going to glycate more cells than if you just had the glucola test before the 2-hour glucose tolerance. Fructose and galactose are not your friends if you're a grown adult and you don't need to grow anymore. So the normal range for an A1C is under 5.7. I would argue you want it to be as low, far under 5.7 as possible, but the official cutoff is under 5.7, you're a non-diabetic. A pre-diabetic is anywhere from 5.7 to 6.4, okay? And then if you have a hemoglobin A1C of 6.5 or higher, that's an official diagnosis of type 2 diabetes. Now, let's talk about the C-peptide test, because a lot of people, it is a newer test, but it's been around for years. But a lot of people don't understand what an excellent proxy marker it is for insulin. So if you see on the left of the slide, this is a molecule called pre-proinsulin in the endoplasmic reticulum of the beta cells of your pancreas. So there's a step, we lose this little purple piece, and then we have proinsulin. Then we have one more chemical reaction, and then we have a molecule of C-peptide and the molecule of insulin. So this is very important. So for every molecule of insulin your pancreas makes, there's also a molecule of C-peptide produced, one to one. Now, insulin has hundreds of jobs in the human body, so it's excreted into the portal vein and it goes about its business. But if you know much about this, you know that your insulin level in your blood changes constantly, whether you've eaten or not, whether you're upset or not, whether you slept good or not last night. And you can only check an insulin level in the fasting condition to give you any meaningful information. C-peptide's not like that. You can check a C-peptide any time of the day or night, and it's going to give you a beautiful proxy marker of how much insulin you're making. It's not perfect, I agree, but it's for a busy medical practice where they're seeing 20, 30, 40 people a day, you can check this C-peptide at 4:30 p.m. and you're still going to be able to get good information about, is this person hyperinsulinemic or not, or even hypoinsulinemic. C-peptide is a great marker for that, and it's relatively inexpensive. So there's a little more information about the C-peptide if you want to read about that. The normal range is 0.8 to 3.85 nanograms per milliliter. Many doctors have never heard of a C-peptide test, maybe even your doctor. Many doctors refuse to order it based on the logic of, if I've never heard of the damn thing, I wouldn't even know how to interpret it. That may be currently true, but you're going to help your doctor understand what it is, why it's so important, and why they should order it on every single adult patient in their practice, pretty much. Any overweight pediatric patient also needs to have this checked. Now, let's do some predictions. We're gonna do some case studies, just like you were in medical school, okay? So pay good attention to these, and you're gonna learn a lot, but also you're gonna see why this new paradigm of type 2 diabetes is so powerful for you as a patient, but also if you choose to help your doctor understand. So we've got a 30-year-old female who has a body mass index of 25, which is not bad. That's pretty darn healthy, eating a paleo diet. Lots of sweet potatoes, lots of spaghetti squash and quinoa. Now, she's got a couple of small skin tags on her neck. She does not have any acanthosis nigricans. We checked some labs on her. Her hemoglobin A1C is 5.5, and her C-peptide is 2.5. And I've got the normal ranges listed there for you. So what's your prediction? What does she have, and what's her risk of developing type 2 diabetes within the next 10 years? You ready? So currently she's metabolically normal, and she's got a low risk of type 2 diabetes because of her BMI, because of her A1C, and because of her C-peptide. Now, she's not completely immune to developing type 2 diabetes. If you start feeding this woman a high carbohydrate diet, she could well move her A1C up and move her C-peptide up and start having metabolic syndrome, hyperinsulinemia, and eventually type 2 diabetes. But currently she looks pretty normal. Now let's do another one. 46-year-old guy with a BMI of 29. So he's overweight, almost morbidly obese with his BMI. He eats whatever. He's in a hurry. He just grabs and eats. He's got several 2 to 5 millimeter skin tags on his neck, under his armpits. He doesn't have any acanthosis nigricans either. His A1C is 5.6. His C-peptide is 4.7. Right? Now, look at this. His hemoglobin A1C is still technically normal, but it's in the upper end of normal. His C-peptide is already elevated. It's already high. So basically, his pancreas is having to make lots of extra insulin in order to keep his blood sugar down at the current level. Now, his pancreas is not going to be able to win this fight for much longer. Currently, his A1C is normal, but it's not going to be normal for much longer. So what's your prediction about this guy? He's hyperinsulinemic. We know that from the C-peptide, and he's got a very high risk of developing type 2 diabetes within the next 5 to 10 years, if not sooner. See the predictive power of this new paradigm? You actually can make rational, logical predictions based on the numbers you see and based on the physical evidence. Here's another case. 52-year-old female. She has a BMI of 31, so she's morbidly obese, but she eats lots of whole grains and lots of fruit and veg. Drinks lots of fruit juice, drinks skim milk because she knows whole milk causes her to have a heart attack, right? We check her labs. Her A1C is 5.9. Check a C-peptide, it's 5.7. What's your diagnosis? What's your prediction here? So with a hemoglobin A1C of 5.9, she's definitely pre-diabetic, 100%. Her C-peptide is very high, so she's very hyperinsulinemic. Her pancreas is having to work triple time to keep her blood sugar down. Even at that point, it's not successful anymore. Her blood sugar is starting to be routinely high. So our prediction is she's a pre-diabetic, and she's going to develop type 2 diabetes within the next 1 to 5 years, 100%, if she keeps doing what she's doing. Next, 36-year-old Asian female with a BMI of 24. That's a good BMI. She's slender. She eats rice, vegetables, fruit. She has no skin tags. She has no acanthosis nigricans. But she does have the tiniest, cutest little pot belly you've ever seen. She's very slender, but got a little belly. And she attributes this. She's had a couple of kids. So she says that's her baby belly. That's just from having the kids. But very slender. We checked her blood, or her bloods, as Ivor would say. Her A1C is 6.5. And her C-peptide is 12.1. What's your diagnosis? What's your prediction? She's a type 2 diabetic, very slender, eating the diet that the American Heart Association and the American Diabetes Association would tell her to eat. She is a type 2 diabetic, but she's still very slender. C-peptide is 12, so her pancreas, the beta cells, are having to work quadruple time to keep up with all the carbohydrates she's eating, and even at that, it can only keep her A1C down to 6.5. She's very metabolically ill. Type 2 diabetic with severe hyperinsulinemia. Now, two things here I want you to learn. First is, many doctors think that the reason you develop type 2 diabetes is that your pancreas burns out and it just stops making insulin. This is virtually never the case. I have checked A1Cs and C-peptides in thousands of patients, and every single patient with who's type 2 diabetic, they have this this constellation of lab results. They have a high A1C and they also have a high C-peptide. Very rarely does the pancreas play out or burn out. They're just exceedingly hyperinsulinemic, and the doctor has no idea because they didn't check a damn C-peptide. Okay. The second thing I want you to take away from this is there are ethnic populations who don't get fat if you feed them a toxic carbohydrate overdose. Caucasians usually will get fat if you feed us too many carbohydrates. But Asian populations and Indian populations, very often they stay very slender, eating a toxic load of carbohydrates, but they do develop that cute little belly pooch and fatty liver. And then they're a type 2 diabetic, just like this lady she's normal size, but she's a type 2 diabetic. Now, here's a trick case. 25-year-old female with a BMI of 21. She's very slender. She eats meat and veg. She's been watching Vinny and eats meat and veg. She has a few little skin tags, but no acanthosis nigricans. We check her labs. She has a hemoglobin A1C of 11.2. Severely, devastatingly diabetic. But look at her C-peptide. It's 0.1. So what's going on with this lady? If there's any doctors out there, you've already figured out what she's got. But for everybody else, what do you think? What's your diagnosis here? She's a type 1 diabetic. That's why her C-peptide is so low, is because her pancreas is not making that molecule that breaks out into insulin. So also she's making no C-peptide. There are thousands and thousands of people who are falsely diagnosed as type 2 diabetics by their doctor because they develop type 1 diabetes later in life. All doctors expect you to develop type 1 diabetes when you're from 3 years old to 13 years old. That's true. That's when most people develop it. But there are people who develop type 1 diabetes in their late teens, early 20s, even late 20s. Only if you check a C-peptide can you tease out, are they type 1 or type 2? Now, there's some other labs you can check, but non-fasting labs, the C-peptide wins hands down every time. So type 2 diabetes, I'm sick and tired of calling it that. It's a terrible name. I'm in the middle of reading Dr. Ben Bickman's book right now, How We Get Sick, and he also agrees type 2 diabetes is a misnomer. It doesn't tell you anything about the condition. It doesn't give you any causative predictive powers whatsoever. But what it really is a toxicity or an overdose syndrome. You're eating a daily overdose of carbohydrates. And for some people, that'll be over 100 total grams a day. For other people, that'll be over 50 total grams a day. For people like me who are very insulin resistant, it'll be if I eat over 20 grams of carbohydrates a day for weeks, I'll start to move towards type 2 diabetes. So remember the story of my neighbor's dog. This is a toxicity issue. This is a poisoning issue, okay? Metabolic syndrome is virtually the same thing as insulin resistance, which is virtually the same thing as hyperinsulinemia. Insulin resistance, I would like to rename this to something that gives us causative and predictive powers. If we stop calling it insulin resistance, that makes it sound genetic or like, we don't know what causes it. If we started calling that carbohydrate-induced hyperinsulinemia, the cause is in the name, but also the solution is in the name. See how handy that would be? What about if we stopped calling it type 2 diabetes and started calling it carbohydrate toxicity syndrome? The cause is in the name. The solution is also in the name. Wouldn't that be handy? Human beings are by design low carbohydrate mammals. That's what we are. If you feed us too many carbohydrates, we're either going to get fat and sick, or we're just going to get sick. Depending on your ethnicity, if you're Caucasian and or Polynesian, you're going to get fat and sick. If you're Asian or Indian or some others, you're not going to get fat, but you're still going to get metabolically sick. And if you call these things by their true name and stop calling them these idiotic names that don't give you any ability as a healthcare provider or as a patient to understand what caused this, how can I prevent it, and what can I do to reverse it or cure it, that's what a name should give you. And I think that's what these names give you. That's my talk, and here's where you can find me on social media. I'm going to stop sharing my screen now, and I'm going to take some questions. How can I do this? Stop sharing. And then get rid of that. Okay, now let's see if we've got any questions. We got a few. All right. Here's a question from Rick. Dr. Berry, one just popped up. This is from Thomas. Will skin tags go away or fall off with improved diet? 100% they will. As you lower, the reason that you're having skin tags come and get huge is because you're hyperinsulinemic. Insulinemia is a growth hormone. That's one of the many things that it does. And it causes inappropriate growth as well. And so you've got your little 1% genetic risk of developing skin tags. But then if you're hyperinsulinemic all the time, these skin tags are going to multiply and they're going to get huge. I've seen some skin tags as big as my thumb, pedunculated. They were a lot of fun to cut off. But I would now, looking back, I didn't know the first few years of my medical practice that meant that patient was hyperinsulinemic. I didn't know that, but now I do. I've cut off thousands of them. But yes, so I've got a YouTube video about skin tags. Look at the comments. There are thousands of comments. My skin tags went away on NSNG. My skin tags went away on keto, low carb, carnivore. My skin tags either got smaller, got fewer in number, or went completely away. And so I'm not surprised that they don't 100% go away all the time, because there's a little 1 or 2% genetic predisposition. But they are going to get, in general, smaller, fewer in number, and some people, they go completely away. Absolutely. Now, let's see. Rick says, Dr. Berry, I went carnivore and my wife Kay is trying, but thinks she needs to add some veg. I watched you and Dr. Saladino on veg toxicity and want her to eat the least toxic veg options. Yeah, thank you for changing our lives. You rock. Hey, thanks, Rick. I appreciate it, man. Some people need to avoid almost all vegetables, all plant foods, and I'm one of those people. I do best and look best and feel best when I eat as close to 100% carnivore as possible. Rick, not everybody has to do that. Your wife may be able to eat some veg, and Dr. Saladino's got great videos about which veg he thinks is the most toxic. And I actually agree with him. I think fruits are the least toxic because plants actually want you to eat their fruit so you can scatter their seeds. So you're going to find the least toxicity in fruits, but you're also going to find the most carbohydrates, because that's how plants get you to eat the fruit, is they make them super sweet sacks of sugar. And so if your wife is developing hyperinsulinemia or already has it based on these labs, she didn't need to be eating the fruits either, even though they're not as toxic as eating the seeds and other things of plants. Peter Ballerstedt, the sod father, sir, says, what do you think of, where'd he go? What do you think of, there he is. What do you think of fermented plant products? I think that fermented plant products are less bad than eating raw raw plants. And so if you're going to eat some broccoli and the seeds, that's what the floret is all the broccoli's little babies. If you truly ferment that, I think it's probably going to be less toxic. You're going to have the microbe that causes the fermentation process is actually going to break down some of the toxins. I don't think that this turns unhealthy foods into healthy foods just by fermenting them, but I think it probably makes them a little less bad. Thank you, Doctor. Dr. Berry, I went carnivore and my wife, I already read that one, sorry. These things keep jumping around. Mike says Dr. Berry is a rock star. Hoo-yah. All right. What are your thoughts on sugar alternatives, erythritol, allulose, etc.? Sarah asked this. Sarah, I think that for some people, for most people starting a low carb NSNG or a keto journey, you can use some of these sweeteners to kind of get you over the hump, to help you break your sugar addiction. But for most people, as they keep eating lower and lower carbohydrate, they either just lose the taste for the sweet, they don't want it anymore, or they find that the artificial sweeteners, even the natural keto-approved sweeteners, actually stall their weight loss, because there's this thing. I'll teach you something else about insulin. There's an innate mechanism in the human body, in most animals, mammals as a matter of fact. It's called the cephalic phase insulin response. And there's research that shows that this is a real thing. If you swish some allulose or some stevia or some Splenda in your mouth and taste the sweet taste and then spit it out, don't even swallow it, that still raises your insulin. And so if you're like me, if you're one of those people that are even on my best day still insulin resistant and your body's trying to be hyperinsulinemic, that little bit of sweetener might be what's causing your weight loss to stall. And I talk about this in my YouTube video about the 13 reasons why you might stall on a low carb diet, is because for some people, even that little insulin bump from the cephalic phase insulin response is all they need to turn off their fat burning. But most people, when they're starting these diets, they can use those as a crutch or as a kind of a bridge to get to ultimately a low carb keto carnivore diet with no sweeteners whatsoever. Johnny says, why have I never lost my appetite? I can always eat something. It's a good question, Johnny. You may not be eating enough protein. You may not be eating enough fat. You may not be eating enough food overall. It's very common if you come to low carb keto carnivore for weight loss, that you still unconsciously, you've got your mother's voice in your head saying you need to eat smaller portions. You need to portion control or portion restrict. Many people do this, and that's one of the things I love so much about low-carb keto carnivores. You don't have to portion size. If you want to eat a ribeye, you can. If you want to eat 2 ribeyes, you can. When you're truly full, your body's going to tell you to stop eating. So make sure that you're not still unconsciously portion controlling or trying to calorie restrict, because none of that's necessary when you're eating what I consider to be a proper human diet spectrum. Siri says, do you have any advice on those with IBS, IBD that may have issues digesting more fat? Yeah, it's been my clinical and personal experience that people with IBS and IBD do better the more fat they eat and the less fiber they eat. You may be thinking about gallbladder issues, eating too much fat, but people with irritable bowel syndrome and disease, whether it's constipation predominant or diarrhea predominant, they always do better when they eat lots of fatty meat. I've yet to see an exception. Robbie says, what about moles? Will moles go away too? Moles are a little bit stickier than skin tags. I have had people reach out on social media and tell me that their moles got smaller. Moles have a higher genetic predisposition than skin tags. If you're from a moley family like I am, then you may stop developing new moles, and your moles may stop getting larger when you eat a very low carbohydrate diet. But I haven't had a lot of people telling me that their moles went away. So I think you're probably stuck with the moles you have, but they'll probably stop getting bigger because you're controlling your insulin by eating a low carb diet, and the insulin's not able to give them that inappropriate growth signal because you're hyperinsulinemic every day. Terry says, why is cheese seemingly a problem? It's fat and protein. Yeah, Terry, I agree. For some people, it looks like that dairy proteins are inordinately hyperinsulinemic. They tend to make people, they for whatever reason, it's genetic or otherwise, some people can eat full fat, real fermented cheese all day long and just lose fat and do great. Other people, if they eat it, the proteins in the cheese are still too inflammatory and too insulinogenic. So it spikes your insulin, even though it's just protein. The particular amino acids found in dairies tend to spike some people's protein. I found this to be true for me. If I eat too much cheese, I'm talking about the real stuff, I will start, my weight loss will slow and I'll start to gain weight. I'll start to get some bloating and some gastrointestinal distress. And I love cheese, so I hate this. But what I'm here is to live my best life and be as healthy as I can be and to help you have that as well. And so I know that cheese, for me, has to be an occasional dessert. It's not fair. It's not your fault, but it is your problem if it is your problem and you need to deal with it. Sarah says, what else is C-peptide used for on labs? Is it only for hyperinsulinemia? Yeah, so you can use C-peptide. It's basically just a proxy marker for insulin production. And so if you have low insulin or high insulin, your C-peptide is going to mirror that exactly. And it's not going to fluctuate if you've eaten or not eaten. So that's mainly what it is. Now, I guarantee you, even though if you read the Wikipedia entry for C-peptide, it says we don't know what it does. I guarantee you the C-peptide does lots of different things in your body. And it can probably be used as marker for other things. But right now we know it is the best proxy marker for insulin production if you're going to check a non-fasting blood sample. How are we doing on time, guys? Are we good?
We got another 10 minutes. And if you want to scroll to the top of the question and answer window, that's where the questions with the most.
So stay at the top. Okay. I've already answered that one. So if you guys see a question that you really want to hear answered, vote for it and it'll push it to the top. Is that?
I believe that is correct.
I've already answered that one.
From Rick, there's a good question there from Mike McIntyre.
Yeah, I see it. I'm looking at it. So Mike says, my doctor says, that's famous last words right there. My doctor says, once you're diagnosed as a type 2, you're always diabetic, even if diet controlled. However, when she plugs my info into the cholesterol calculator, she marks me as type 2, even though my A1C is under 5.0. That skews the risk factor, and it makes her think you need a statin. Yeah. So, and remember the story about my neighbor's dog. When my other neighbor stopped poisoning the dog, did the dog's mercury poisoning go into remission? Would we say about that dog, that dog always has mercury poisoning, but it's just in remission right now? You sound like an idiot if you say that, right? There are diagnostic criteria for what type 2 diabetes is. Very black and white. If you meet them, you're a type 2. If you don't meet them, then you're not a type 2. This is one of the idiotic things that doctors say that I'm trying through my book and through my YouTube series to try to get doctors to stop saying stupid shit, because this is stupid. Yes, you have cured your type 2. You've cured your prediabetes. You have a beautiful, exquisite A1C. Congratulations, by the way, for that. And ask her if the cholesterol calculator, if it actually uses the LDL in the calculation or not. That'll get her thinking cap on. But no, you're not a type 2 diabetic anymore. You're not by the diagnostic criteria. So go back and respectfully, lovingly teach your doctor to stop saying stupid things. Do you recommend a continuous glucose monitor for someone who is trying to wean off insulin? Gina asked. Yeah, Gina, any diabetic, whether type 1, type 2, Modi, Lada, all you guys need a continuous glucose monitor. There is no tool on the planet that gives you more instantaneously useful information than a CGM. And if you have any diagnosis of diabetes, whether type 1, type 2, LADA, Modi, your insurance should pay for a CGM. Okay. And back to the previous question, even though you've cured your type 2, I would still let her keep putting type 2 diabetes on your chart. That way the insurance will keep paying for your little monitors, for your CGM. But yeah, I think it gives you such excellent information. Like, for example, some people can eat a big serving of broccoli and their blood sugar will hardly move. Other people, I'm one of them, can eat a big serving of broccoli, even cooked in butter, even with cheese on top, and my blood sugar is going to spike up. That's too many carbohydrates for me personally. So I think the CGM is just an invaluable tool. If you have ever had a blood sugar that's 1 point high in your entire life, you're going to benefit from having a CGM, because within a month's time of using it, you're going to have a list of foods that most keto people and all doctors would consider that's a very healthy food. But because of your personal CGM results, yeah, I can have a bite of that, or I can have none of that because it's going to spike my personal blood sugar. I think that's invaluable information. Let's see. T says, OMAD, what are your thoughts? So OMAD still stands for 1 meal a day. What are my thoughts on that? That's probably 4 days out of the week. My dietary regimen is OMAD. I'll break my fast about 2 to 4 p.m. I'll eat a huge meal that's 1 or 2 ribeyes, maybe a pound of ground beef, maybe some ground sausage that's 0 carb, maybe anywhere from 2 to 6 egg yolks, maybe some cod liver, maybe some fish roe mixed in with my 0 carb mustard. And if I don't get hungry again that day, I won't eat again that day. But if we have something going on in the family, we're going out for a meal, or if I do get hungry, I'll eat a second meal a day. So pretty much every day of my life is OMAD, or 2 meals a day. And I think it's an excellent tool. Now, if you're still eating a high carbohydrate diet, good luck going OMAD. You're not going to be able to do that because you're going to be too hungry all the time. Why does stress cause you to want to eat even after the moment has passed? Can you avoid this somehow? Lisa, that's a great question. It's actually, the answer is multifaceted. So definitely there's a bit of, where did it go? It keeps jumping on me. So definitely there's a bit of carbohydrate addiction in answer to your question. Many people use carbohydrates as comfort. They use it to console themselves when they're under stress, when they're pissed off, when they're bored, when they're lonely, when they're depressed. They use, and everybody says it's comfort food, or it's, you're soothing with food, but it's comfort carbs. And you're soothing with carbohydrates, because carbohydrates light up the dopamine centers in your brain, the pleasure centers. We know this from the PET scan evidence. And so keep cutting the carbohydrates. That should get better. But also when you're under stress, whether it's acute stress or chronic stress, that keeps your cortisol level chronically high. That's going to increase your hunger as well. And so if you've got some chronic stress in your life, whether it's a bad spouse or a bad job or whatever, you got to fix that. Or if you can't fix it, you got to learn to deal with it and let it go. And that'll help your cortisol level go back down. Let's see. How do you convince a doctor to order a C-peptide test? That's an excellent question. So there are doctors out there who will just flat out refuse to order that. They'll say, I don't know what it is. I don't know. I wouldn't even know how to interpret it. Well, your doctors just admitted their ignorance to you out loud with words. And so you've got various ways to respond to that. You can either see that as a huge red flag that your doctor is a haughty moron and find a new doctor. Or you can say, well, doc, I do understand why I need it. Can I explain it to you? And maybe you could print off a couple of the slides that I use in this talk and say, see, C-peptide and insulin, they literally start out being the same molecule. Then they split apart. So if you check my C-peptide, you're going to know how much insulin. And I would have, 10 years ago, if you'd come to me and asked for a C-peptide, I would have said, I don't even know what that is. What are you talking about? But if you sat down with that and said, no, look, this is why, I would have been like, oh, okay, yeah, I'll order it. I don't care. But some docs are very haughty. It's not a pretty scene in some doctors' offices, and they're just not going to do that. You need to find a new doctor, or go on my C-peptide videos. I actually have a link for a online lab where you don't even need your doctor's order. You can order your own damn C-peptide and tell your doctor to go and do whatever you'd like to tell him or her to go do. I answered that one. We all know, this is from Kevin, we all know low carb reduces blood pressure, and we know it's a result of chronically high insulin. But some of us have been taking pills forever, and when we try to stop, BP tends to rebound to elevated levels. So what is a good range of BP for people who are resolving their insulin resistance issues, and how do you advise they keep it low without meds? Okay, this is a very, I could talk for an hour answering this question, but I'll try not to. So first of all, some blood pressure medications, when you stop taking them, there is a rebound effect. Notoriously for the older blood pressure medications, you'll have a huge rebound when you stop taking them. That's not dangerous, okay? That's temporary. It lasts a day or two, maybe a week at most, and then that's going to go wash out and go away. That's first and foremost. Second of all, many people don't check their blood pressure properly. If you run into your doctor's office hurriedly and you're late, or he's running behind, and they rush you in and check your blood pressure, that's not a real blood pressure. I used to not even want to know what the person's blood pressure was at the clinic. It's going to be falsely high every time. I want to know what your blood pressure is when you're home, calm, relaxed, sitting quietly for 15 minutes. That's a real blood pressure. So any other blood pressure checked at a doctor's office, I don't even want to hear what it is. I don't care if it's 250 over 150. It's irrelevant. If you all jumped up out of your seats right now and did 50 jumping jacks, and then I checked your blood pressure right after that, it's going to be high. That's normal. If you got mad at me and wanted to yell at me and end this presentation, and I checked your blood pressure right then, your blood pressure will be high. That's completely normal. That's not dangerous. That's not a sign of pathology or disease in any way. So don't let your doctor check your blood pressure in their office and then say, oh, see, it's high, you still need this pill. That is all the research was done on someone sitting quietly in a dark room for 15 to 20 minutes. Then they check their blood pressure. That's how you check a real blood pressure reading. Okay. So I hope that at least partially answered your question. I want to try to get to a few others. I've got several videos about high blood pressure on my YouTube channel that might help a little more. I already answered that. One and that one. Okay, from Jessica, is a premenopausal woman, if a premenopausal woman is on the carnivore diet to lose weight, is it better to have a higher fat ratio than protein ratio? Jessica, I think the honest answer to this right now is we don't know exactly, and it seems to depend on the person. There are women who do wonderfully on a very high fat, moderate protein carnivore diet. There are other people who seemingly do better with a high protein, moderate fat carnivore diet. I have great respect for Ted Naiman and his PE diet, and some people follow that and they do wonderful. Other people seem to do better with a higher fat, moderate protein. I think that this is one of the many things we as citizen scientists get to experiment with our N=1 and decide which works best for me. So if I were you, I'd pick whichever one you like the best. And for most people, that's high fat, moderate protein, and do it for a month. And then if you're liking your results, keep doing it. But if you're like, nah, I gained a pound or I didn't lose any, then try the high protein, moderate fat for a month, see how that does. I think it's better for different people. That's not really a question. I answered that one.
You got one more minute, Kim.
1 minute. Okay, let's see. Here's a great. Now, see, Todd's a thinker. I like this, Todd. Do you think that the sense of smell triggers an insulin response? And I don't think there's ever been any research done on this, Todd, but I 100% predict that you have an insulin response. If you walk into your mom's kitchen, it's Thanksgiving, and she's cooking that damn chocolate cake that you used to smash, but now you don't eat anymore, I guarantee you that gives you an insulin response. It raises your insulin at least a little bit. If you walk into McDonald's and smell those French fries, I would bet $1,000, €1,000, which is more than $1,000, that bumps your insulin. Now, we don't know that for a fact. It hasn't been proven yet, to my knowledge. If anybody knows the research, please shoot me a link. I'd love to see it. But, I mean, you got to live your life, right? You got to go to Mama's for Thanksgiving, even if she's cooking that damn chocolate cake. But, yeah, I bet it does. How's that, guys? Does that wrap us up?
That does. I'm going to come back on screen for a second. Here we go. So thank you so much, Dr. Ken. This was great. Thank you, everybody, for being here. My hair is all crazy for some reason. We will be coming back in 10 minutes with Dr. Brian Lenskis. Everybody remember that Nina Teicholz will be at 4:30, even though it doesn't say that on your schedule. And remember, if you have an interest in NSNG foods, we're offering 20% through Tuesday with the promo code SUMMIT. So again, thank you, Dr. Ken, and we'll see you all in 10 minutes.
All right. Thank you, guys. Listen to Dr. Brian.